Imagine you have a fire raging in your living room. You panic, you hit the emergency button, and the high-pressure sprinklers kick in, the fire goes out. You've basically solved the immediate life-ruining problem.
Right. But a few months later, you look down and realize the constant water pressure has just completely warped and rotted the hardwood floors beneath you.
Exactly. Fixing a glaring, immediate crisis inadvertently created this silent structural one right underneath you. And today, we are looking at a massive new piece of medical research that reveals this exact dilemma is happening right now in the treatment of endometriosis.
It really is the ultimate pharmacological trade-off. We are incredibly adept at targeting a specific disease process. But the human body is, it's a tangled web. You pull one string to fix a problem, and a totally separate system just starts to unravel.
And navigating that unraveling is our mission today. Welcome to the Deep Dive. Whether you're a clinician catching up on research between appointments, maybe you're a patient actively managing your own health, or you're just someone fascinated by how the human body reacts to modern science, this conversation is for you.
Absolutely. And the source material today is phenomenal.
Yeah, we're pulling apart a landmark systematic review and meta-analysis. This was published in the journal Obstetrics and Gynecology in 2026.
And the scale of this work, it really cannot be overstated. We are talking about screening over 1,000 studies to distill decades of fragmented data into one cohesive picture.
We definitely have to introduce the people who actually did that heavy lifting. We're looking at the work of lead authors Jade Desilets, Rosa Lakabi, and Alicia Olstorn, and that's along with their wider research team from Trillium Health Partners and the University of Toronto.
It's a powerhouse team for sure.
It really is. So, our goal for the next little while is twofold. First, we are going to translate their data to understand exactly how different hormonal treatments for endometriosis affect the human skeleton. Second, we are going to explore how this data needs to radically change long-term patient care plans.
Because to really understand the data, we have to first understand the biological catch-22 of endometriosis itself.
Right. Let's set the stage there.
So we are talking about a chronic, deeply painful condition. It affects up to 10% of women and people assigned female at birth. Tissue that's similar to the lining of the uterus basically grows outside the uterus on the ovaries, the fallopian tubes, the bowel.
And that causes severe chronic pelvic pain. It can lead to infertility, and it drastically limits a person's ability to just, live their life.
Exactly. And the engine driving that abnormal growth, the fuel for the fire, going back to your analogy, is estrogen.
So the logical medical response is to starve the fire. You introduce therapies that suppress the body's estrogen production.
That's the standard approach, yes.
But as I'm thinking about this, estrogen isn't just an arbitrary reproductive hormone. Isn't it fundamental to keeping the skeleton intact?
Oh, it is the master architect of the skeleton. Think of your bones as a highway that is constantly under construction.
Oh, okay, a highway.
Right. So you have a demolition crew. These are cells called osteoclasts that tear down old, micro-damaged bone. And then you have a paving crew, the osteoblasts that lay down fresh, strong bone.
So it's a constant cycle of renewal.
Yes. And estrogen is essentially the foreman of the demolition crew. It keeps the osteoclasts in check so they don't, tear down more road than the paving crew can fix.
Ah, I see. So if a medication suppresses estrogen to stop the endometriosis pain, you're basically firing the foreman.
Exactly. The demolition crew goes rogue, and they start tearing down the bone way faster than it can be rebuilt.
Which leads to a rapid drop in bone mineral density.
Yes, very rapid. Historically, if you gave a patient a powerful estrogen-suppressing drug, like a gonadotropin-releasing hormone agonist or a GnRH agonist without any other support, they could lose 4 to 6% of their bone density in just 6 months.
6 months? Wait, that is a massive structural compromise.
It's huge.
But medicine obviously couldn't just let patients' bones dissolve, so what was the workaround there? If we know suppressing the hormone causes the bone loss, couldn't we just, give them a tiny bit of estrogen back, just enough to act as the foreman for the bones, but not enough to fuel the endometriosis?
You've just described add-back therapy perfectly. That became the gold standard compromise.
Okay, so how does that look in practice?
Doctors prescribe the heavy-hitting drug to shut down the estrogen factory, but simultaneously give the patient a low-dose hormone. This could be like a progestin or a combination of estrogen and progestin, or even a synthetic steroid called tibolone.
And that's the add-back.
Right. It slips just enough hormone back into the system to protect the skeleton, theoretically keeping the disease starved, but the bone safe.
Theoretically. But if this add-back loophole worked so well, why did Desilets and her team at the University of Toronto even need to do this massive review? I mean, does the add-back shield not actually hold up?
Well, it holds up, but it is not a magic freeze ray. It slows the damage, it doesn't stop it entirely.
Oh, I see.
And remember, patients with endometriosis are dealing with a chronic disease. They aren't on these medications for a few weeks. They're on them for years, sometimes decades, just to function.
Right, because it's managing a lifelong condition.
Exactly. So the Toronto team realized that even with add-back therapy, the bone architecture was changing over time. We desperately needed to quantify exactly how much bone was leaking through the cracks of these different treatment strategies.
Which brings us to the core of the research. Let's look at how the body actually reacts to these strategies. Starting with the one we just talked about, the GnRH agonists combined with that add-back shield. What happens to the bone density after 6 months?
So the meta-analysis pooled data from hundreds of patients on these agonists with add-back therapy. And at 6 months, they found an average decrease in bone mineral density at the lumbar spine of 0.89%.
Wow. So even with the shield, they are losing nearly a full percent in half a year.
Yeah, and at 12 months, that reduction creeps up to 1.50%.
So it's a steady drain.
It is a steady drain. But the researchers uncovered something highly unusual when they dug into the specific chemicals used within this class.
Yeah, I noticed this in the data. They looked at two very common agonist formulations, right? Leuprolide and goserelin.
Correct. And biologically, they do the exact same job, tricking the brain into shutting down the ovaries.
But the bone impact wasn't identical. I mean, leuprolide showed a statistically significant 1.33% drop at 6 months, but goserelin only showed a 0.42% drop, which statistically was a non-significant blip.
It is a really profound quirk in the data. Both drugs were used alongside add-back therapies that the review found were, generally comparable in their protective power. Yet, one formulation hits the skeleton 3 times harder in that early window.
How is that physiologically possible? If the brain signal is the exact same, why does the bone care which chemical sent it?
It likely comes down to pharmacokinetics, which is how the drug moves through and is processed by the body.
Okay, break that down for me.
Well, these drugs are often given as depot injections or implants that release slowly over a month or sometimes 3 months. The exact delivery mechanism, the specific molecular half-life, or even how smoothly the drug achieves a steady state in the bloodstream, all of that could cause subtle fluctuations in those estrogen levels.
Ah, so it's not a perfect on-off switch.
Exactly. Even microscopic variations in how deeply the estrogen factory is shut down can change how aggressive that bone demolition crew gets.
That seems like a monumental detail. I mean, if I'm a patient choosing between a drug that drains 1.3% of my spine or 0.4%, I'm obviously going to want the 0.4%.
Assuming the pain control is equal, absolutely. It highlights that the chemical formulation itself is an independent variable in bone health.
Okay, so if the GnRH agonists represent a strategy of a steady drain on the bones, did medical science try a different approach? Is there a way to treat the disease without just bludgeoning the estrogen factory into shutting down completely?
Yes, and that leads us to the progestin strategy. The review heavily analyzed a drug called Dianogest.
How does that work compared to the agonists?
Progestins work differently. They don't orchestrate a total systemic shutdown of the ovaries from the brain down. Instead, they create a local environment that is incredibly hostile to the endometriosis lesions themselves.
So it attacks the lesions directly?
Basically, it shrinks them and prevents recurrence while also stabilizing the uterine lining.
So if it's not a total system shutdown, the bones should be safer, right?
You would think so. But the data showed that Dianogest was associated with a 0.83% drop in bone mineral density at 6 months and a surprisingly steep 1.91% drop at 12 months.
Wait, 1.91%. That's actually a heavier loss at the 1-year mark than the heavy-hitting agonists with add-back. That feels completely counterintuitive.
It does, but we really have to look at the broader clinical context that the researchers point to here. With Dianogest, the bone density drops sharply in the first year, but then, based on wider long-term literature, it plateaus.
It plateaus.
Yes. The body seems to find a new, albeit slightly lower, baseline equilibrium. The demolition and paving crews basically match pace again.
So it's not a steady drain, it's more like a step down. You lose a chunk up front, but then you're relatively stable.
Exactly.
I imagine that makes it a much more viable option if, say, a 25-year-old needs a medication she can stay on for the next 10 years.
Precisely. If you're looking at a decade of use, a drug that drops 2% and stops is infinitely safer than a drug that drops 1.5% every single year.
That is a crucial distinction. Okay, so we have the steady drainers, like the agonists, and the plateaus, like Dianogest. What about the newer generation of drugs? The GnRH antagonist drugs like elagolix, relugolix, or linzagolix.
Right, the antagonists.
How do they work differently than the agonists?
If an agonist is like overstimulating an engine until it stalls out, an antagonist is like just walking up and snipping the spark plug wires. It blocks the receptors directly, causing an immediate, profound drop in estrogen.
And how did the bones react to the spark plugs being cut?
Violently. The pooled analysis for GnRH antagonist showed a massive 2.17% decrease in bone mineral density in just 6 months.
Hold on a second. We're comparing 2.17% for antagonists against roughly 0.89% for agonists at the 6-month mark. But earlier you said the agonist patients were taking add-back hormones. They had a protective shield.
Yes, they did.
Were these antagonist patients also wearing the shield?
The data actually backs up your suspicion there. The review explicitly notes that the antagonist trials they analyzed mostly lacked add-back therapy. It was just the raw drug suppressing the system.
So it's not a fair fight. We are literally comparing shielded bones to unshielded bones.
It is an apples to oranges comparison if you just look at the raw percentages. But the researchers included this because it proves an immensely important concept for treatment: dose dependency.
Dose dependency, meaning how much of the drug you take.
Exactly. Antagonists are unique because you can easily adjust the daily pill dose to control exactly how much estrogen you suppress.
So instead of a massive monthly injection that you can't take back, you can fine-tune the dial on a daily basis.
Yes. And the researchers highlighted a trial that proved this beautifully. They looked at elagolix.
What did they find?
When patients took a lower dose, 150 milligrams once daily, the bone loss was moderate. But when they ramped it up to 200 milligrams twice daily to fight really severe pain, the bone loss accelerated drastically.
It perfectly illustrates the mechanical trade-off we talked about at the start. The more aggressively you attack the disease, the more violently the skeleton pays the price. You just can't cheat the biology.
You really can't. The precise regimen, the exact dose, the frequency, and the presence of a protective add-back hormone determines the fate of the bone.
Let's round out the treatment strategies with one more option the review covered. That's DMPA, which most people know as the Depo-Provera shot. Where does this fit in our mental model of drainers and plateaus?
DMPA is a bit of an outlier, actually. The review looked at 4 studies and found that at 6 months, patients on the depot shot lost about 1% of their bone density.
Which falls right in line with the others, generally.
It does, but there's a catch with this one.
A good catch or a bad catch?
A significant, mostly good one. Decades of data from using DMPA as a contraceptive show that this bone loss is highly transient. Especially in younger patients, once they stop the injections, their bone mineral density typically rebounds right back to where it started.
Oh, wow. So the highway paving crew catches up and fixes the road.
Exactly. They get back to work.
So we can organize this complex medical data into 3 really clear takeaways. We have the transient drops, like the depot shot, where the bone bounces back. We have the plateaus, like Dianogest, where you take an initial hit, but then the body stabilizes. And we have the steady drainers, the heavy-duty agonists, where the bone just slowly leaks away year after year, even with an add-back shield.
That is an excellent way to synthesize the pharmacology.
Yeah.
But translating that pharmacology into actual patient care is where the University of Toronto researchers uncovered a massive systemic problem.
Right, because a 1.5% drop on a spreadsheet is just a number.
Exactly.
What does that actually mean for the human being sitting in the exam room? If I'm a 30-year-old patient and my doctor says, good news, your endometriosis pain is gone, but your lumbar spine lost 2% of its density, I mean, how panicked should I be? Am I going to break a rib coughing?
And this is the most sobering reality check of the entire publication. Clinically speaking, we have absolutely no idea what that 2% means for you.
I'm sorry, what? We can measure the exact fraction of a percentage of bone loss, but the medical community doesn't know what the consequence is.
That's the truth.
How is that possible?
It comes down to the tool we use to measure bone density, the DXA scan. It's a fantastic piece of technology that measures the grams of calcium and minerals packed into a segment of bone.
Okay, so the tool works.
Yes, but that tool, and really the entire medical framework for understanding what a dangerous score is, was built and validated for postmenopausal women.
Ah, women in their 60s and 70s who are naturally losing estrogen.
Exactly. The massive epidemiological studies that correlated a specific bone density score with the likelihood of snapping a hip, those were done on older populations.
I see.
But here we are talking about 25, 30, 35-year-old individuals experiencing chemically induced reversible estrogen suppression. The biological resilience of a 30-year-old bone matrix is fundamentally different from a 70-year-old bone matrix.
It's like having a high-tech digital speedometer in a sports car, and it's incredibly accurate at telling you you're going 85 miles an hour.
But there are no road signs.
Right, so you have absolutely no idea what the speed limit is or if you're about to fly off a cliff.
That is the exact clinical dilemma. A 2% drop in a postmenopausal woman is a well-understood warning sign. A 2% drop in a 28-year-old on Dianagist might just be a harmless temporary plateau. We simply do not have the long-term fracture data to know when to sound the alarm for this specific demographic.
Which means doctors are kind of flying blind when they write these long-term prescriptions. If they don't know the speed limit, how are they deciding when to pull a patient off a drug?
They look to the clinical guidelines and the warning labels on the drugs themselves. But the authors highlight that because of this data vacuum, those guidelines are a contradictory mess.
Give me an example of that. Let's go back to those two identical agonist drugs, leuprolide and goserelin, the ones where one drained 1.3% and the other barely registered. What did their rule books say?
Well, if a physician pulls up the product monograph for leuprolide, it is covered in red flags.
What kind of red flags?
It explicitly warns to use with extreme caution in patients at risk for osteoarthritis. It warns against using it for more than 12 months without careful consideration. And it mandates assessing bone mineral density before even thinking about a second course of treatment.
Okay, very strict parameters. So what does the label for goserelin say, considering it operates on the exact same biological pathway?
The goserelin label simply says to use with caution in patients with known low bone density.
Wait, that's it?
That's practically it. There are no strict duration limits recommended. There is no mandate for routine bone scanning.
That is wild. You have two drugs from the same class doing the same thing. A doctor could read the first label and think, I need to aggressively monitor this patient's skeleton every few months. Or they could read the second label and think, I can just write this prescription for the next 3 years and not worry about it.
And that cognitive load, that confusion, falls squarely on the shoulders of the prescribing physician and ultimately the patient. This is the primary so what of the entire meta-analysis. Desilets, Lakabi, and Olstorn argue forcefully that this Wild West of prescribing guidelines just cannot continue.
Because endometriosis is not a disease you cure in a month. If a patient finds a therapy that finally allows them to get out of bed, go to work, and live a painless life, they're going to want to stay on that therapy indefinitely.
Yes, and right now, without standardized rules, patients are either being left on bone-draining medications for years without any skeletal monitoring, or they're being prematurely pulled off medications that were safely plateauing.
And throwing them back into chronic pain.
Exactly. And often out of an unfounded fear of osteoporosis based on data meant for someone 40 years older.
So the demand here is for the medical community to sit down, look at this exact data, and write a unified, standardized rulebook.
Yes. A consensus on exactly when to scan these patients, how to interpret those scans for a 30-year-old, and when the bone loss actually justifies changing the treatment.
A customized, heavily monitored care plan for every single patient.
Medicine has to acknowledge that every single month a patient is on these life-changing therapies. A physiological toll is being exacted on their skeletal foundation.
We have covered a massive amount of medical territory today. Let's take a moment to pull all these threads together and summarize the core takeaways from this 2026 review for you.
It really all stems from an inescapable biological trade-off. Estrogen fuels the debilitating pain of endometriosis, but it also acts as the vital foreman that builds and protects the skeletal system. Suppressing the disease inevitably leaves the bones vulnerable.
And when we look at the data, we see exactly how that vulnerability plays out across different strategies. We have the transient therapies like DMPA, where bone density drops about 1% but bounces back. We have the plateau therapies like Dianagist, which cause a sharper drop of nearly 2% over a year, but then stabilize, making them viable for the long haul.
Yes, and we have the steady drainers, the GnRH agonists, which slowly chip away at the bone year after year, even when we try to protect them with add-back hormones.
And the final critical takeaway is the call to action for the medical system. We are using diagnostic tools built for 70-year-olds to measure the bones of 30-year-olds.
Exactly. Until we have long-term data on what a 2% bone loss means for a premenopausal patient, we cannot rely on contradictory, outdated drug labels. We need unified, specialized monitoring guidelines right now.
Which leaves us with a truly profound final thought for this deep dive. Modern pharmacology has essentially handed endometriosis patients a miracle in one hand and a ticking clock in the other.
That's a great way to put it. These medications do something incredible. They give people their immediate lives back. They stop agonizing pain today, but they do it by borrowing structural strength for the patient's future. The great philosophical and medical challenge moving forward is figuring out how to balance the desperate need for quality of life. For the patients sitting in the room right now, with the safety of the skeleton they are going to rely on 3 decades from now.
It is the ultimate tightrope walk. We figured out how to put out the fire in the living room, but now we have to invent a way to save the floorboards before the house caves in. Thank you for joining us on this deep dive into the data. Keep asking the hard questions, keep looking past the surface, and take these insights into your next study session or your next doctor's appointment. Catch you next time.